Good afternoon, students. Welcome to R.A.T.S. Racing Against Time for Students in Pathology. In this session, I shall be starting Haematology. Without much of an introduction, I shall be going into the various phases of Haematology in small sections. The first one shall be anemia and its classification. The importance of it is given in the enclosure. The point is, this might be asked as a question, or very frequently it is part of an essay question. How do you define anemia? Generally, the students say that it is a decrease in hemoglobin. They are partly correct, but then I would like this definition. Anemia is defined as a deficiency of hemoglobin and hence the oxygen carrying capacity of blood specific for the age and sex of the patient. If a male patient has got 12 grams of hemoglobin, it is abnormal. Whereas if a female has got 12 grams, it can be considered normal. Similarly, it will be varying for the child according to the age. So the definition is a definition. Do not vary from it. Classification is an aid to orderly thinking. And this particular classification of anemia has been taken from a text called De Cruci. And along with that, there are other books such as Tejinder Singh and a book that I shall be showing you towards the end. The classification of anemia can be as follows. 1. Anemia due to blood loss. It can be an acute blood loss. The patient has met with an accident or undergoes a major surgery, etc. Chronic blood loss, as in a female with menstrual bleeding. Nutritional deficiency. This is classical, you people will be aware of it. It can be either iron deficiency or megaloblastic anemia. Along with that, protein malnutrition, vitamin C deficiency, etc. can also be causes of anemia. Sometimes anemia is due to systemic diseases such as infections, renal failure, liver diseases, example cirrhosis, disseminated malignancy, collagen disorders such as SLE, thyroid and pituitary disorders. So these directly have got nothing to do with hematopoiesis, but then can be a cause for anemia. Also, anemia can be because of bone marrow disorders. The classical example being aplastic anemia. And the others can also be a precursor for an anemia. Bone marrow infiltration, dyserythropoiesis, sideroblastic anemia, and myelodysplasia. I would like you people to kindly by heart this particular tabulation, and please note it is not complete. So this is the first half of the classification of anemia. There is another group of anemia called as hemolytic anemia. And hemolysis means there is a destruction of the RBC, which can be because of intracorpuscular defects. The defect is within the RBC. That is why it is called as intracorpuscular. Most of them are congenital. It can be a membrane disorder again, red cell membrane disorder, as in spherocytosis, elliptocytosis, or stomatocytosis. All these are membrane disorders. Also, there can be defects in the hemoglobin, such as sickle cell anemia, thalassemia, hemoglobin C, hemoglobin D, a combination of sickle cell and thalassemia, etc. The third group will be enzyme defects. Defect in pyruvate kinase deficiency, G6PD deficiency, and also it can be an acquired pyruvate kinase deficiency. So these are all enzyme defects. It can be membrane defects, hemoglobin defects, and an enzyme defects. The next is extracorpuscular defects. Defect is not within the RBC from without. One major complication is immune system. And under that we have got autoimmune disorders. There can be warm antibodies and cold antibodies which can cause hemolysis. Hemolytic disease of the newborn, you people should be very well aware of. Incompatible blood transfusion. You give a wrong blood transfusion, there is a hemolysis. One can be an RH incompatibility or it can be an ABO incompatibility. So all these are defects of the immune system, but it is of extrinsic etiology. Whenever I say immune mechanism, there can be non-immune mechanism also. Under that I have got cardiac hemolytic anemia. What will happen to a patient who has been fixed to the prosthetic valve? There is a mechanical damage, lysis of the RBCs. March hemoglobinuria. Whenever soldiers are asked to march long distances, there is a crush artifact of the RBCs leading to hemolysis. Microangiopathic hemolytic anemia is also a form of hemolytic anemia that can be seen in disseminated intravascular coagulation, etc. Then there can be miscellaneous causes. Drugs and chemicals, infections, burns, lead poisoning, snake bite, etc. So ultimately you find that anemia is due to a plethora of conditions. It is not a disease in itself, but a manifestation of a disease, just as jaundice. There is another method of classifying, namely morphological classification. Under this, based on the size of the RBC, we have got a microcytic hypochromic anemia, normocytic normochromic anemia, macrocytic anemia, and dimorphic anemia. So this is called a morphological classification. In microcytic hypochromic, I find that the main parameter is the MCV, mean corpuscular volume, less than 80 femtoliters. The causes are iron deficiency or thalassemia. Normocytic normochromic, all the red cell indices are within normal range, and it can be because of recent blood loss, hemolytic anemia, renal failure, bone marrow infiltration. Macrocytic anemia, when the size is more than 100 up to 130 femtoliters. Up to 80 is supposed to be normal, but then it is massively increased. It happens in megaloblastic anemia, liver diseases, as well as in some aplastic anemias. Dimorphic anemia, di means two. So it is a combination of micro and macrocytic or normo and microcytic or macrocytic. So it can happen in cases of combined deficiencies, in pregnancy where there is a deficiency again. Response to treatment. A patient is anemic and you give treatment, there can be a response producing normal cells. And finally, sideroblastic anemia. Look at this one compared with the lymphocyte. The WBCs are all reduced and they are appearing pale. It is a microcytic hypochromic. It can be an iron deficiency, but in thalassemia also, it has to be ruled out. And this is a normocytic normochromic anemia. Compared with the lymphocyte, again, the cells are of the same size. There is no variation. The pallor is also standard. Or sometimes it can be macrocyte. Look at these cells. The cells are large. When compared to the lymphocyte, these RBCs are larger. Some of them are oval. So it is a case of macrocytic anemia. So this is called a morphological classification. Have this in mind. What are the clinical manifestations of an anemia? There can be usually general manifestations such as definitely lassitude, tiredness, fatigability, because the function of the RBC is to carry oxygen, and when there is deprivation of oxygen, all these features can be there. Pallor of the mucosa and conjunctiva for the same reason. Dyspnea on exertion. Obviously, when a patient is climbing a flight of stairs, there can be a dyspnea. Palpitations and murmurs. As I told you earlier also, there can be what is called as hyperdynamic circulation. Hyperdynamic. You people can see the pulse, you need not feel the pulse. It can happen in a number of conditions. A for anemia, B for beriberi, C for cirrhosis, D for ductus arteriosus, E for exercise, emotion, G for Graves' disease, H for hypertension, I for increased infusion of fluids, and so on it will go on. Angular cheilitis, glossitis, koilonychia, we shall be seeing all these features later on, and pedal edema. These are the general manifestations of an anemia. Look at these pictures, contrasting but yet both are anemic. In one, I am finding an absolute pallor. Those days, the doctors are advised to look at the sclera and the conjunctiva of the patients. And the doctor's nail bed itself is supposed to be a comparison. The doctor is not supposed to be anemic. So the pallor can be very well appreciated. So there is an absolute pallor over here. In this, there is an yellowish discoloration, mainly because the bilirubin has got an affinity for the sclera. Therefore, it gets deposited over here. It can be found in the mucosa and the skin as well, which will be developing an yellowish tinge. And compare this. I find that there is a spoon-shaped deformity of the nails. There is a depression over here. We shall be seeing that in detail. Koilonychia is the name of the condition. And as we had seen earlier, there is a definite set of anemias called hemolytic anemias. Under that, you have got jaundice, cholecystitis, cholelithiasis, leg ulcers, splenomegaly, abdominal pain, and there can be other features as well. So obviously there is a jaundice which we can make out. These are all gallstones. So this condition is called as cholelithiasis or the formation of the gallstones. A lot of causes are there. One such cause can be hemolytic anemia. Because of this, the patient can develop leg ulcers, classical of sickle cell anemia and spherocytosis. Splenomegaly can be seen. Abdominal pain because of increased destruction. And there can be the other features such as hyperdynamic circulation, etc. All can be seen in a case of hemolytic anemias. This is a chronic leg ulcer I have been describing, can be seen in patients with sickle cell anemia. And this incidentally is a text that I had authored called One Page. Students, welcome to R.A.T.S, Racing Against Time for Students in Pathology. The short topic for the day shall be bone marrow aspiration. The importance of it is given in the enclosure. In pathology, you should be remembering two things as far as hematology is concerned. One, the peripheral smear. Two, the bone marrow. And this topic shall be dealt with under the following subheadings. What are the sites, indications, needle, procedure, biopsy, stains, dry tap, complications, and reporting. Too many of them is it, but always think of the subheadings. The subheadings will lead you to the answer. It is a very strict aseptic procedure that has to be done at least in the minor OT or in a sterile enclosure. I find that here the physician or the pediatrician is performing the aspirate and there is a syringe over here. And look at this one. This is the posterior superior iliac spine. Probably the patient is made to lie in a knee chest position so that the bone is more prominent and an aspirate is done. But coming to the bone as such, there is something called a cortical bone outside, which has got an outer table and then finally an inner table as such. The inner table, it will be containing a spongy bone. The spongy bone, and part of it will be the marrow. In fact, there is something called the yellow marrow and the red marrow. The red marrow will be containing the cellular elements. And here, once the needle is inside, once you cross the cortical bone, there will be a sense of giving in, as though it has yielded. Now you feel less resistance and the aspirate is done. These are a couple of needles which can be used. The first one is Sala and the other one is Clima. The needle itself is short and stout. So always remember the needle is short and stout. What I see over here is the stylet. The stylet is also a part of the needle, but once it is within the marrow, the stylet is removed and the aspirate starts pouring in. Even otherwise, I can attach an ordinary syringe and perform the aspirate. This is called the laterally adjustable guard. Guard means there is a screw-like thing. Depending upon the thickness of the bone, this can be adjusted. For example, if you are going to do a bone marrow aspiration in a young child, this can be pushed even further up because the bone is much thinner than the adult, whereas in an adult it can be lower down. So this is a lateral adjustable guard. This is a Salas needle. Another needle is also there which is almost similar, but it doesn't have a lateral guard. That is called Clima's needle. So these are the parts of the needle. As I had mentioned earlier, it has to be done under very strict aseptic precaution. The site of aspirate is cleansed. If there is hair, it has to be shaven, and the skin and the subcutaneous tissue indurated with 2% xylocaine. After waiting for some time, the aspirate is performed. Once the needle is within the marrow, the stylet is removed and a syringe is attached, and not more than 0.2 to 0.3 ml of aspirate is obtained. I repeat once again, this I will be asking as a question. 0.2 to 0.3 ml of the aspirate. Some people are very liberal and they produce us with 5 to 10 ml of aspirate, which is diluted. The sites of aspiration are: one is manubrium sterni, two is anterior superior iliac spine, three posterior superior iliac spine, four is tibial tuberosity in children, and vertebrae again. These two are last choices and these three are commonly done. The advantage of the anterior superior and the posterior superior iliac spines are when the patient is made to lie down, he is not seeing the aspirate. Whereas in the manubrium sterni, there is a chance of him staring at you, stabbing at his chest. There is another entity called biopsy, and the needle used for it is called the Jamshidi needle, which can be a reusable needle or a disposable needle. In this, what happens is the tissue is caught within the needle and it is removed. So the histomorphology is preserved. It can be used for the diagnosis of a metastasis. Sometimes repeatedly when you aspirate also you don't get material, that is called a dry tap. And for this a biopsy can be done. Lesions such as tuberculosis, storage disorders, etc. can be diagnosed by means of a biopsy. And the needle is a Jamshidi biopsy. Please remember bone marrow aspiration, bone marrow biopsy. What can be the complications of this? I would like you people to kindly draw this diagram. These are easily drawable. This is an aspiration needle and this is showing the stylet inside, whereas these are the biopsy needles. The complications can be infection if it is not done under a sterile procedure. Hematoma can be caused. There can be damage to the underlying structures, particularly when it is done in the manubrium sterni. We can damage the heart or the great vessels. Uncontrolled bleeding can be present in some cases. Dry tap. This can be because of technical error, because of marrow fibrosis, or sometimes too much of cellularity also. The cells also can come and block the needle. So I'll have to withdraw the needle and go in a different direction or perform in a different site. So these are all the complications. You people will have to make a list of them. What are the indications for a bone marrow aspiration? There are three headings. One is absolute indication, relative indication, and non-indications. Absolute indications means without the bone marrow, I cannot make a diagnosis at all. Look at this one. This is a marrow over here. These are all the fat spaces. Normally, it should be about 40 to 50%. In this section over here, I'm finding nearly 80 to 90% only fat. That means it is a case of aplastic anemia. Aplastic anemia cannot be diagnosed without a bone marrow. Megaloblastic anemia, because megaloblasts are demonstrated in the bone marrow. ITP, idiopathic thrombocytopenic purpura, because I'll be finding immature megakaryocytes in the bone marrow. Multiple myeloma is again a classical bone marrow disorder. So these four are absolute indications for bone marrow aspiration. Relative indications means it can be tuberculosis, it can be a Hodgkin's lymphoma, it can be a metastasis, it can be a storage disorder, etc. So these are all relative indications. Non-indication means a hemolytic anemia is a classical example. It is not at all indicated in a hemolytic anemia. Please remember these headings and what I had told you people. Absolute indication, relative indication, non-indication. And this is a bone marrow aspirate. I shall come to this. And this is the smear that you people have prepared. There are two methods. One is a squash. I just keep another slide over it and make a smear. I get this kind of a picture. Or it can be made by an angular smear. And these are all the bone marrow particles. And when I draw, these will be leaving behind cell trails. So these are examples. And this again is a squash preparation, not much cellularity, but this is a thing with a good cellularity. And this again is a bone marrow smear, which I had shown. We will be dealing with it gradually. You find that there are too many components over here, but let us remember these subheadings. Cellularity, erythropoiesis, leukopoiesis, megakaryopoiesis, lymphocytes and plasma cells, mitosis, myeloid erythroid ratio, abnormal cells, parasites, and iron stores. These headings I have obtained from JIPMA and it has stood the test of time. What are the stains that can be done? These are the following stains: Leishman stain, May Grenville Jamesa, the right stain, or the right Jenner Jamesa stain. Sometimes cytochemistry is done for the diagnosis of leukemias. Pearl's Prussian blue, I had shown you earlier picture in iron deficiency for demonstrating the iron stores. And this is a slide for multiple myeloma. Gracias.